All right. We're talking about pediatric cardiac arrest. Okay. What are we doing first?
I'd like to just quickly, we don't work a lot of pediatric, where we really don't have a lot of pediatric patients. And most of us probably have not worked, and at least I'm guessing, a pediatric cardiac arrest in a while, which is a good thing. I'm not real prepared today. Tasia is taking care of me on my PowerPoints, and she had sent me pediatric cardiac arrest ones that we had done 2 or 3 years ago. And the file was corrupted, long story short version, so I'm not going to beat you to death with PowerPoints, thank goodness. One thing to remember about, and you probably already know this, that a pediatric patient generally does not just go into cardiac arrest. I mean, unless they have a congenital problem, electrocution, etc. But about 9% of the time, it's due to other factors. It's only medical as far as cardiac, about 9% of the time. What I'm getting at is most of the time, the pediatric patient goes into respiratory distress and then respiratory failure. And from that point, they start bradying down and go into cardiac arrest. The key is prevention. And that's not just with pediatric patients, that's with your adult patient also. But it's more, it's very important to be able to assess your patient. You don't have to know all your drug doses. As a matter of fact, I'd recommend you don't try to remember any of them. That's why you have a Brazo tape. But you need to be able to assess your patient properly and be able to pick up on signs like when the patient is starting to become respiratory compromised. Because once they get to that failure point, if you don't intercede to do something, use your magic, so to speak, they are going to go into cardiac arrest. And once a pediatric patient arrests, it's pretty much Katie bar the door. We as medics and EMTs can prevent that from happening. Like I said, just be prepared and know the signs, symptoms when your patient is going to decomp and arrest that particular problem before they go into cardiac arrest. And that being said, all of you know as much, if not more, about treating a pediatric patient. I don't work that much on the truck anymore. I try to stay current, but one of the failings, probably all of us, is the pediatric side. Most of the patients we carry or transport are the geriatric populace instead of the pediatric. My advice to you would be go to some pediatric conferences. ACH does podcast. A guy named Charles Woolley, who's a student of mine back many, many years ago. He has a podcast, and they have physicians from Children's Hospital spend an hour talking about, cardiac arrest or child abuse, etc. So that's a good way to learn about pediatric patients. Also, I think most of us, not most, some of us in here has been to the Tucker Redfern Pediatric Conference. It's not just medical. It's very little of it is actually medical. It's trauma, but still they go into some cardiac arrest situations. So my advice, since we don't do a lot of pediatrics, is stay current, which unfortunately I haven't stayed as current as I should have. All that being said, not to bore you, Tasia has pulled up a case study. It's more of a trauma based, but it's a good one because this particular patient, I looked at it briefly before I came in here. If some intervention wasn't done, this patient would go into cardiac arrest. She's going to share this scene or this slide with you.
All right, so I'm sorry it's not up on the TV. Those of y'all that are in Zoom land should be able to see it well enough. However, the internet keeps dropping, so I'm on my mobile hotspot on my phone, and it's not recognizing the TV because of the Chromecast. Different IP address. So pediatric emergencies, case study.
You got the mic.
You and your partner are completing morning chores at the station when you are dispatched to treat a child who fell from a third-story balcony. When you arrive in the quiet subdivision, you are flagged down by a frantic mother who points toward her 2-year-old son. You then see a toddler lying face up on the driveway approximately 3 feet from the house. The mother tells you that she turned her son over but did not move him any farther. So same size that primary survey, what are we thinking?
Bullshit.
Yeah, or if you're in this location area, that's your primary initial thought.
Mhm.
If you're metro, obviously not.
Oh, yes,
And in this particular, I want you to talk mostly. This is actually in a metro area because they have a level 1 trauma center. You'll see that at the end of where they took this patient to. But you're absolutely right. Fulton County Hospital, Baxter Regional, they're not qualified to take care of that pediatric patient
Mhm.
when you see the injuries that they have. So that, have you looked at this particular
Yeah.
slide? Okay.
I
In
used it
your
last year,
opinion-
it's been a
okay.
while, but
In your opinion, here, you would stabilize this patient and you want them where at Children's Hospital?
well, this brings up a point that we were discussing. I think I put it in the supervisor chat about burns. And we were talking about where exactly do we take
Yeah.
burns when they're moderate to major? Because it was, yeah, it was Traumacom that suggested here. And then when Johnny was in here,
Yeah.
he said the reason why they did that is because they went, when they picked up,
Mhm.
they went straight to Children's and I don't know if they got in trouble, but they weren't real nice to them.
I think I like Johnny's very, very smart guy, good educator, great educator.
And humble,
And
we learned.
He really is.
Yeah.
I've known him a long time, but here's the thing, you're gonna do what's best for your patient.
Yeah.
I saw a picture you sent me, your patient. They should have went to a burn center.
Mhm.
Maybe they should have taken him to Mercy. I don't know.
I think he did. He went to Cox or Mercy, one of the two.
The
but
one that you had.
Yes.
But the one he would say he had a problem with, they took him to Children's.
Yes.
So the Children's is a
Instead of
pediatric hospital.
pediatric burn, you go to Children's.
Right.
But an
An
adult burn,
or go to the med.
and that may have been why
But-
they chose to go to
But
Springfield.
here's the thing, and we're getting off topic, and that's fine. But what Johnny's right, that ATC said bring them here. Okay, you're gonna bring this patient here.
Don't delay
It's
care.
gonna
to
delay
me.
care for hours.
Yeah.
Hours. Because then they're gonna have to find a placement for him.
Mhm.
I would have blown him out. After what you showed me, he had second, third degree burns. It
Mhm.
looked like, well, what about close to 30%? I don't know. I
I'd say
couldn't
more
really,
than that.
more than that. He needed to go to at least a level 1, but a burn center.
Yeah.
But anyway, here's the thing. How many of us have been chewed out before? But it didn't bother me. That doesn't bother me a bit.
So would Baxter be appropriate? I think that was the question, because we have our 4 majors, STEMI, hot belly, moderate major trauma, go to Baxter. So
Right.
a moderate to a major burn.
They're not really, they're not a burn center either. And you know
Right.
that as well as I. That's a very good question. They're probably not gonna be happy with you showing up for that.
I don't think
patient.
anybody's gonna be happy with
Nobody's
it.
gonna be.
Yeah.
And Fulton, to be perfectly honest with you, because they don't need a surgeon,
Mhm.
okay? They didn't need to be intubated. Fulton would be as appropriate a facility, and this is an opinion, as appropriate as Baxter for that particular type problem.
Yeah.
Okay. They can do what that patient needed done here. Like Baxter's not going to keep that patient.
Right.
So
it's another delay in care.
It's
It's
a
even
delay-
more
it's a
delayed
delay in
care
care.
than what it would be here.
and they're not going to be happy with you showing up with that patient.
More
Why did
so.
you bring them here?
Yeah.
We're not a burn center. Of course, same thing here at Fulton. We're not a burn center.
Mhm.
Of course, you're probably going to be treated a lot nicer.
Yeah,
I
my
would
question about, if they're severe enough, do we just go ahead and run to Mercy?
Yeah, I guess
Let
we
me
could have.
tell you what trauma. We're getting way off.
Oh, we are,
pediatrics,
I'm sorry.
But no, it's
Well,
fine.
no,
I'm
technically
gonna tell
not.
you.
I
I'm
mean,
gonna tell
we're
you
talking about
exactly what the
children's,
trauma system
like
says today.
hospital, so their capability.
There's no point in bringing them to, if it's a major multi-system
Mhm.
trauma. Here, Baxter, White River, they need level 1. It's what they recommend. They can't force you to do this. What they recommend is you get that patient and you head to a level 1. Now you can have a rendezvous with flying.
Oh, yeah.
But that's their recommendation, and we're 2.5 hours away from any level one.
Right.
Isn't that right? Little Rock may be a little far. I'm saying Springfield's about what, 2.5 hours?
You're 156 miles to UEMS, 153 miles to Mercy, and 159 miles to the Med.
So you're 2.5 hours away.
So is Baxter gonna have a problem with that?
Pickup in the main,
Okay,
and he took off.
right there at the Missouri state line.
Well, it was like right in the middle. It was in the middle.
Okay.
But he took off for Springfield, and I remember Schultz just blew a gasket like he's good at.
One thing about Schultz, he's a very smart guy, but he gets real bent out of shape pretty easily.
He does.
But he's smart, and I like him. We've known each other forever. But he doesn't really, he's not a big proponent of the Arkansas trauma system. That's just Dr. Brad. But that doesn't surprise me
I
at
mean,
all.
Gerald didn't have a problem.
Well, he got on to me in Bowen. Schultz. You remember that motorcycle wreck we had right there by the New Hearts? Little boy got mangled up. Well, we called for a bird to come get him from there. And when we got back, Schultz jumped our butt because we didn't bring him to Baxter first.
Yeah, he jumped on me for going straight to Aerovac base.
Yeah, that's Brad.
You know, I said, I just told him they was already ready to go. They already had the helicopter warmed up, ready to go when I got.
I just think you should do what's best for the patient. Take an ass, this is cruel, take a behind chewing. Happened many times. No, me, hopefully it'll be the last pretty soon for me, but anyway, let Tasia, let her move on, and that's basically what you see, you know, looking from the door, so to speak, although it's not inside.
The toddler is lying motionless. His eyes are open, but he does not focus on you or his mother as she stands crying beside him. You observe an adequate respiratory rate with good bilateral chest expansion. The boy appears pale and has cool, dry skin. So what are we thinking?
That head.
Definitely
Got
his
the
head.
head.
Okay.
Very good.
So what kind of shock would that be?
Well, you're not gonna lose, here's the thing, and you'll see this as you go later on, and you already know this also. Yeah, you're not gonna become, as long as it's closed, hypovolemic from the head in.
Mhm.
It is gonna compress, you know, the brain at some point and cause some significant problems.
Neurogenic.
If he's shocky, if he's shocky, it'd be neuro. But they're gonna change horses on you a little bit here in a minute.
All right. The appearance, pale toddler lying motionless, making no eye contact. Level of consciousness, he's alert to verbal stimuli. Airway is open. Breathing is at an adequate rate in volumes. No retractions or audible sounds. Circulation, weak radial pulses with pale, cool skin. So do we remember what happens to the respiratory rate and the blood pressure in neurogenic shock? What goes up and what goes down? Okay.
Yeah, because you lose your ability to vasoconstrict,
Mhm.
amongst other things. But this particular, you go anyway. You're right, and we're not seeing this kid. We're seeing a slide presentation, if you will.
Mhm.
So it's much more difficult for us to determine right now what's going on because it's all written down.
Yeah.
We all know, at least I work better hands-on if I can see that patient, lay
Right.
hands on them. This kid's got a problem,
Yeah.
and we don't know enough at this point what it is. Tasia's right. Mike is too. If it's neuro, you might be thinking, okay, at this point, by their skin color, it's pale, weak pulses, you probably think, okay, this is probably some type of shock right now, but you're gonna find that, yeah, it's not, he's not in shock yet. But it's impending, isn't it? If something
We need to
isn't done,
consider it. at
you
least.
consider it.
Yeah.
That's a smart person does that, and you critical thinking say, okay, right now everything may be for him falling so far hunky dory, but it's not.
Right.
And it's going to change, and we all know pediatrics change rapidly.
Yeah.
It's like they're good one minute, and then the next minute they're dying. So
One thing that we really emphasized in class was you can be in two different types of shock too, and not just
Oh,
one.
yeah.
So, I mean, what type of shock is a code? Cardiogenic.
Cardiac,
Yeah.
What made me think of shock was the paleness and
It
then
would.
making no eye contact on a 3-year-old.
Yeah.
3-year-olds usually locked in on mom.
I think he's 2 years.
2-year-old.
But anyway, the thing is, one thing that's gonna, if you'll go back,
Two.
if you'll go back to the slide you were just on. Okay, they do have radial pulses, although they're weak. Okay, once they lose their radials and don't have a brachial, you know, at that point it is starting to, yeah. This person right now, you haven't seen the vital signs, and the reason I know this is because I've already looked at it. I would be going down the same, not a rabbit hole, but the same direction. The patient is not in decompensated shock at this point.
Mhm.
Although by looking at it, I think it's going to happen.
Mhm.
So go a little further. Kid has a head injury, but that's not the only thing.
Right.
And I had the luxury of looking this up about 15, 20 minutes
Yeah.
ago.
Well, going back to what you were saying earlier about don't rely on your memory on your dosages and
Mhm.
stuff. That's what they drill in PALS, and it was what they drill in medic school
I
is
know.
to know those
Okay,
dosages.
I got to tell you, I'm as guilty. I did that when I taught it. Basically, you had to remember these. You had to, and that's fine for an academic setting. Okay, but let's be honest, you don't use your pediatric meds very often. So my thing is, and I had a really good medic instructor many years ago. He said, "Don't tell you something. The key is look stuff up, don't screw it up, especially with pediatric medication."
Mhm.
Thomas tells a story about penguins. His brain is an iceberg. All these penguins. And he says, "Don't tell me something new because you're not going to penguin off that I need to keep." So I'm not going to remember P doses because I'm going to rely on the Broslow or the PD wheel or the knockoff. We have knockoff Broslows. That's just me. I'm an old man. I can barely remember my name sometimes. Now, an adult, you're going to know your common medications. You don't need to look them up. You should know them. How many can quote every pediatric medication? I can't. But at one time, not everyone, but everyone that we would probably use.
0.1 and 0.01.
Yeah. But I'm not going to try to remember that. I'm going to get my tape out. There we go. Yeah, that was go to the
Why
next
they're made
slide.
for.
I don't have to get out of here.
What assessment tool will you use to form your general impression of the patient?
Oh, what's that called? Patient assessment triangle. Is that right?
The PAT provides emergency care providers with a quick, hands-off approach to patient assessment. It can provide you with information about your patient in less than 30 seconds without touching the patient. The 3 legs of the PAT, appearance, breathing, and circulation, will aid you in determining whether the child is sick or not sick. The PAT will also assist you in figuring out the physiologic status of your patient. Is this patient in respiratory distress or failure, in shock, or experiencing a neurogenic problem? Yes. Yes? Yes to all 3?
Wait, no. What was, read the first 2. They're not in respiratory failure.
Not yet.
Is the patient in respiratory distress or failure?
They're not in
Not
failure.
yet.
Okay, and shock?
Well, yeah, no, you're right, but it's compensated.
Yeah.
No reason for that because I went through this slide.
Okay,
And
so,
do your drink.
or are they experiencing a neurogenic problem? Is it shock or is it a neurogenic problem? Which you've already stated it's not the shock.
Later in this, you'll see that they're not, you don't have enough information right
Right.
now.
We're at 0
Where we would
minutes
see
in
it,
the-
if we were there,
Do you remember
we
these?
would see
Did you do
this. You know what I'm saying? If we were there, we would
They-
see what is wrong with
Right.
the patient. But here's the thing, they fell, how many stories was it? Three stories. That's a long fall. Now,
Mhm.
they're gonna have a head injury. But think about what could happen to the other parts of the body. The
Mhm.
head isn't the only thing that hits, the whole
Yeah.
body does. This patient's gonna have some multi-system problems.
Mhm.
The head is the worst thing.
Mhm.
It really is. A head injury in a pediatric patient is worse than a femur fracture.
Mhm.
Thing is, you don't lose that much blood with an isolated head. Well, you're not going to, because unless it's open, there's no place to go.
Right.
At some point, you're going to have herniation of the brainstem, but hopefully that's not going to happen.
Yeah.
But the patient isn't in respiratory failure at this point. And truly, they're not in, quote, by looking at the numbers, you'll see not in decompensated shock.
So how many patients do we have?
You got two, very
Good.
We're
good.
about to have mama going into
Yeah.
shock,
Great.
What can you do to assist the mother?
comfort, talk.
Comfort, maybe give her a little O2. You'll know you're doing something for her.
Exactly.
Vital sign.
Give her a little bit of
There
ketamine.
may be some bystander that seems to be have their stuff together, because
Yeah.
she's not injured. Psychologically, she is.
Yeah.
So maybe there'll be a bystander, or maybe there's a law officer there that can comfort her, because your hands
Have her give you.
are
Provide
tied with
information for the child.
with the infant, right? Or the pediatric patient.
Good.
But it just calm her. That's excellent, Mike. And
Well, we had that one last night. Seriously, we had a ped last night.
I heard.
2-year-old not breathing
Were they really not breathing?
for a little bit.
Okay.
Then it'd been diagnosed with flu A, and then they had a febrile seizure, which my dad, I mean, he freaked out. That's his only kid. It's his first kid. I mean, I'm just saying the truck didn't go very slow when I heard peds and 2-year-old.
Yeah. You know what I'm thinking.
That's a time to fly.
I mean, the old 13's got some juice in her. We got there, and then the dad come running out, panicked when we got the little girl. And dad was freaking out, but luckily, Grandpa was a first responder from Mammoth that had got there. And when we got on scene, Dad was freaking out. We got the baby in. I started playing Grandpa, got the baby calmed down. We got some O2 saturations on her. She was 98. She was good, had a low fever. Dad started panicking. So I let Allison and Grandpa do their little thing, talking. And I got him calmed down. Dad finally wasn't doing all this. Got him here. He was calm. It was 2-year-old. Freaked me the hell out.
Well, we don't run on them that often. But you guys are right, you guys, ladies, are absolutely right. Is you do have two patients, and rightfully so. If that was my child, I'd be a little panicked too.
So are you gonna say, what are you gonna do for, what are you gonna say for comfort?
We're doing everything we can.
I mean, that's what we done,
We're gonna
man.
get him to a facility that will be able to do more than we can.
And last night I did have a hard time. Mama wasn't there. Daddy was. Mama was talking to Grandma or her mom and demanding, "Oh, it's got to go to West Plains. I want it to go to West Plains." I was like, "Man, we're Baxter. We got just as much ability to assess than what West Plains. But my big deal is let's get her there. Let's get her checked out instead of driving another 45 minutes to an hour. We got a 10-minute drive. And if it needs something more, we can get it to wherever a bigger appropriate facility. But we got her handled now." And Dad was kind of starting to relax. And, I mean, I just tell him the bigger ain't always better.
True.
That's good. All right. So you use the PAT to form a general impression of the patient. Based on his abnormal appearance and circulation, you determine the child is sick and requires rapid treatment. The combination of your knowledge that children are more prone to head injuries than adults because of their larger size and weight of their heads as compared with the rest of their bodies, The mechanism of injury and your general impression of the patient leads you to suspect that the child may have a closed head injury. You immediately assign one of your firefighters the task of maintaining manual C-spine. You ask your partner to apply 100% supplemental oxygen via non-rebreathing mask. Are we still going to do that?
That's kind of controversial. What is the O2 sat? We don't,
I don't,
Okay.
yeah, I don't think we have it yet.
the problem, and Tasia's right, as far as these patients that have head injuries, you're really not doing them probably justice throwing 100% oxygen on them. The standard of care used to be that you not only put high flow oxygen, you BVM them. But actually, that is probably detrimental. Because and Doug and I were talking about this the other night. We were talking about acute coronary syndrome, but oxygen is a drug, but what it has a tendency to do at some point is cause some constriction. So you really don't want that constriction. So 100% oxygen. Of course, you're going to go by your protocols, and I imagine your protocols are say you give this patient high flow O2, and it's saying they're non-rebreather. At some point, you may even BVM them. And we got to go by our protocols, but I think there's going to be some changes. I know there is as far as ACS treatment, because there's been studies done that patients, unless their stat is less than 94, you don't even put them on oxygen. If it's unstable angina, non-STEMI or STEMI, because it will cause some constriction and you're actually going to increase the end parts.
Well, if you think about this, though, you're talking about vasoconstriction. Isn't that what you want with a head bleed?
Head bleeds, yes, but the problem that you're probably going to be that anyway because you got to bleed and there's pressure on the brain. So the kid, it's not going to be indicative when it shows you the vitals on this patient. You would think that this patient's pressure would be higher, but it's not because there's something else going on, which they haven't given you. Saying, and you're making really more so if it's a stroke patient, okay?
Yeah.
As opposed to a closed head injury. There's a big difference. Well, a stroke is a closed head injury, but it's not due to trauma. So in those patients, yes, definitely. On this patient, depends on some other factors. What is their respiration rate? What's their SpO2? And treat your patient because no two patients are exactly the same.
Right.
But Tasia's right. You're probably going to see a change in the way things are done now in the next couple of years. That doesn't really answer your question.
On this, I don't know if I'm right or wrong with some of these that we've done with the like 3 and 4 year olds.
Mm-hmm.
I will do a blow by with them.
Yeah.
I'll just hold it. I won't put nothing on him. I'll just hold the mask. Is that not?
I mean, they're getting something.
Yeah.
Should I not do that?
No, that's fine. I think a lot of times, and we know this is pediatric patients don't like their face to be covered up. Now, this one obtunded, if they are, they're not going to be able to bite you and try to take the mask off. But a patient that's coherent that you think needs oxygen, they're not going to like a mask on the face. But the blow by using a cup or whatever, or just using a mask, that works fine.
The only difficulty I see with it, and I think it's a great idea, is that it's going to be all hands on deck. So you're going to be busy doing an assessment in that mask. I don't know. I mean,
You're talking about this.
Yes.
Yes, you're absolutely
Yes.
right. You don't have if you do a blow by, you basically can do nothing
attached.
else.
Yeah.
Well, I mean,
You're dedicated
I'm
to
just
that.
going back to that one that we had here that the dad had his little infant and it quit breathing in the car seat and he came in and threw it at us. Well,
Yeah.
he was with me and he just threw it. So the first thing I did is just grab the mask. We done a blow by. Then I just set it on the pillow and had it aimed and it was just blowing.
Yeah, there's nothing wrong with that. That's good care.
And it's just another option. So you've already got one Lucas holding C-spine.
That wasn't one.
Lucas.
Oh,
That's
you're
what I call
funny.
firefighters.
Oh, okay, I didn't know what you're talking about.
Could you not slide that non-rebreather between them two fingers while he's holding C-spine?
Mhm.
Let him hold that above it.
That's
Yeah.
a good point.
You're thinking.
Well, I mean, I'm just,
I
I
hate
never,
somebody that comes up with a good idea that's simple. No, that's great. He's right on.
never thought about that. I'm just-
We're gonna have to go through this pretty quick. I got a meeting at 10 o'clock this mandatory.
Okay, so, well, I got another question. If we don't get through all of it, it's fine.
You can do
And we-
it.
Yeah,
too. You realize
so TXA,
on this patient?
Yeah.
Okay, that's a good question. You're gonna see that this person has more problems than just the head injury.
mhm,
And that is a good question because I'm not sure if a head injury is a contraindication to use TXA.
was there an age contraindication? to TXA?
I would think probably anybody less than 6, but I know that for sure. No, I could look it up. I could look it up. I'm sure there is probably an age that you don't give it if they're less than.
Yeah.
And a lot of things I've read, and I'm just not really trying to blow smoke here, but a lot of things they don't recommend you do on somebody under 6 years of age.
Mhm.
I don't know about TXA. I don't know.
Why
But
would
with
it
this
matter?
patient,
Most adults and children of all ages can take it. Right, my doctor.
Okay, I wonder if that's on our pediatric tech.
We'll just have to pull it out
I
and
would
look.
have to look, but I would be
doubt it.
surprised if
Yeah,
it is.
'cause that's more of a code tape
Yeah,
than
it
it
is.
is.
Or for rest prior. You're right, it is
Yeah.
more.
The risk side effects would be vomiting, diarrhea, or nausea.
I have that when I go to Chins.
So, yeah.
All right.
Moving on. All right, you're 5 minutes in, so
Can I stop? You
Yeah.
missed something on the last slide.
I did.
Yep.
Oh,
Okay.
okay.
Look at about after the your examination reveals a mildly distended abdomen and an obviously deformed right thigh. So now you're looking from, okay, it's an isolated head injury
Mhm.
to we have multi-system trauma. a
Which
femur
we'd
fracture.
already considered.
Right.
Yeah,
Because you think of the patient as a whole, this patient, because I've looked at this and cheated, but they have a femur fracture and they also have a bleeding internally.
Yeah.
So now you're thinking, okay, this patient is losing volume. They're not losing it externally, but you can lose a lot of blood in the femur with a femur fracture, be it an adult or a ped, and also in the abdomen, because now we're thinking, okay, yeah, they got a head injury, but they're also going to become hypovolemic.
Yeah.
And I just wanted to point that out because, and like I said, I cheated and looked at this earlier.
So could this qualify as multi-system shocks?
Oh, yeah.
Because he's got neurogenic, traumatic, possibly psycho, because
It's
he
for-
he fell and that's tripped him up. You know, whoa, crap, what happened to me?
Psycho.
Okay, there's,
Oh.
can I butt in? And this is just like splitting hairs, and I'm sorry, I don't. The kid has a neuro issue, okay, but it's not, usually a neurogenic shock, you're paralyzed.
Mhm.
Okay.
It's a spinal cord issue as opposed to the brain. It's a neural problem, but it's not really neurogenic shock.
So what shock are we considering?
You're going to consider it being hypovolemic because if you're going later on the slide, because it's going to explain how much fluid or blood the ped can lose in their femur fracture and abdomen. So they can lose a lot of blood, and it doesn't take much. This is a little bit older child, but when I was teaching and did a lot of research back in that day, and I could remember things, if you had a ped that was about that age and they had a bruise on their abdomen about the size of a man's fist, they could lose enough blood to become hypovolemic. So it doesn't take a lot of blood for a pediatric patient to become hypovolemic.
So what happens to the vital signs in hypovolemic shock? We talked
Well,
about.
they're gonna heart rate increases. They're gonna compensate as long as the brainstem is not affected.
Yeah.
So they're gonna compensate, and Shane is absolutely right. The heart rate is gonna increase the respiratory rate. The blood pressure is gonna be the last thing that changes and
It's gonna
falls.
take.
And once that happens, you're behind the 8 ball. You should think, Okay, this
Good.
kid is in compensated shock,
Mhm.
and you want to prevent that kid from going into uncompensated or decompensated shock, because then they're gonna be hard to get back. So Shane is absolutely right. This kid is breathing in Reed 40 times a minute. Now look at that blood pressure. That's a good blood pressure.
Oh, yeah. For
And
now.
actually, blood pressure for a ped, if they're under, what is it? Help me tell you, 10 or 12, I can't remember. It's usually 70 plus their age is the low end of the blood pressure. This kid's blood pressure, a normal would be 72. You're not concerned if it's 72.
Right.
86 is good.
1 to 2 years is 73 to 110 systolic.
Okay. As long as it's over 72, we're good as far as blood pressure.
90
But
systolic.
what
Right.
she said is, look at that rate. This kid is already starting to compensate
Mhm.
because they're breathing really rapidly and their heart rate is 170. That is not normal for a 2-year-old. So they're compensating at this point. So you need to do some interventions.
Ireland, quick.
So, risk, where we're looking at, heart rate, 90 to 150.
The 170 is too much. I mean, it is. 40 is too much. So they're trying to, what they're doing is when they're losing this blood, and we all know this, because of that, the kid is going to become just like an adult acidotic.
Actually, the respiratory rate's not terrible, 25 to 40.
I think
But it's on the
40
higher.
And one thing is, it's to me, it's too high.
Yeah.
And your little thing there, I'm sure it knows more than I. But
It's children's.
this
It's probably not.
I'm sure they
updated.
do
It's
know
probably
a lot
old.
more. But I'll be concerned about this kid because of the
normal,
rate
there's nothing
and
wrong.
the pulse rate. The
Mhm.
blood pressure, I'm happy, but it's going to change. The capillary refill is a little prolonged, isn't it?
Yeah.
So going to the next slide, because I have to leave in a minute.
So what do you need to monitor in route? All of it.
Everything.
All vitals.
Respiratory, blood pressure,
No.
respiratory,
Keeping
all
company,
respiratory.
keeping
All
the
Cat
vital
pose.
signs. What's that next one? What interventions?
Which interventions would you consider?
Me personally, even without even reading this before, is I want IV access.
Yeah, IV
Mm-hmm.
access fluids.
Because this
Warm.
kid is going to go into
Warm fluids.
warm fluids.
Mhm.
This kid's blood pressure is going to start tanking, and they're going to need a crystalloid bolus.
Mhm.
And we know from all the classes we've been to, children's or in here or wherever, that now the standard, I think, is 20 milliliters per kilogram that you give them that fluid bolus. And you're going to see later on, yes, I did read it, but I didn't know that this kid needs a fluid bolus.
I like
fluid
the way
challenge.
that the fluid boluses are set up now, because you're 20 for peds and you're 200 for adults.
Yeah. See,
So,
it's simple.
very
Things
simple.
used to be so jacked up,
Yeah.
it was hard to remember everything.
Yeah.
But
So-
that's what you're going to think about.
Controversially, are we going to backboard or not backboard?
I would never backboard unless the only time I would backboard, and I'm being honest, is if you need to move a patient. You need to get them out of a vehicle, off the ground.
Even if we knew that they hit their head and have a possible bleed?
Okay, here's the thing. If you probably the PD immobilizer would be something better than a board. A board, even not so much a ped patient, but an elderly, they should never be put on a board
Mhm.
because of the pressure points.
Right.
It causes B cubes, etc. But a backboard has never been proven to be advantageous. The reason we use backboards is because they were used during the Vietnam War. And it was no studies done on them. I've seen x-rays, years ago, went to a conference, and this doctor was before his time, said, those things need to be burnt.
Mhm.
He said, they have no purpose on your truck. He showed numerous x-rays. He was from Conway. I don't remember his name. He was used to be an EM medic, but he wasn't Calicott. I can't think, anyway, it doesn't matter. But looking at the patient on the board, and the C collar looked great. And they took pictures, and the spine was way out of line. So backboard has never been proven efficient. The kid needs C-spine stabilization. But a backboard is really not gonna help this patient. And that's just not me saying, it's a lot of data and research that I've done on it. They still are part of our mandatory things we keep. And I'm not saying don't do it,
I'd rather
okay?
more than just lay them on the cot, and take the
Yeah.
board out.
Because have you ever laid on, let's quickly, so I don't have to leave. I'm stupid. So years ago at Independence County, we boarded everyone like every other service did. And they would stay on that board and we'd transfer them to UAMS. My idiot self decided, I wonder what that feels like. So I wrote a board back from UAMS to Batesville. And
Strapped down or
It
just,
wasn't strapped down because they had the cot strap.
yeah,
It's the most uncomfortable thing I've ever done. And I thought at that point, this is a torture device and it has no point in EMS. That's my opinion. But the data is starting to show that you're being detrimental to your patient. But now the key to mobilizer is a little bit different. It's padded. So yes, you're right on using that. But a board,
like I said, I like using it to move the patients to the cot, like down a steep hill or whatever.
Perfect. It's perfect. And out of a vehicle.
Yeah, and then just,
I use it as a slide board.
Yes, sir. It has its purpose, but not as a mobilizing patient.
you use it as a slide board.
Guys, I got to go.
Well,
I'm
just-
sorry.
I mean, like that wreck we done over here with the 5 boys. I mean,
You gonna lock it?
No, I unlocked.
Unlock it,
I
okay.
use it as a slide, to slide them on, and then we got them out of the cot. And
Yeah, that's what, yeah.
I mean, and then to get people out of a car
Or in a car.
or in a car that shouldn't be.
But she is home on hospice.
Let's don't
DNR.
even talk. Well, let's don't even talk. Let's just,
I'm just saying.
okay, good. Carry on. I don't want to think about that one.
Well, I've got some good news. This is kind of off topic, but it's been 2 weeks before I went to Bondwood. I don't know about anybody else.
Shut up. Because let me tell you what, last night at 4 o'clock in the morning, coming back, we got canceled from Fondwood.
Did you really?
Yeah.
Oh, we did Saturday night.
You did Saturday night.
Yeah.
Okay, never
You
mind.
got canceled?
We got diverted and then she called back and told them, no, never mind.
Yeah.
I wonder about APS. Me calling APS. If
I don't
they had
know, that's
anything
why I
to
was
do
trying
with
to
it.
call you Saturday night.
Oh,
Was to see if we needed to have them call them while we were on the way out there. Because she was hearing voices.
I would just call after the fact because they're going to ask a lot of questions and you're going to need your face sheet for it.
We got diverted to a very weird call.
Okay. All right. Well, I'll take that back then. I've done that statement. All right. Am I using words that are too big? Just asking. You weren't the only one that said that last week. So you know what rescind means?
Yeah, you're taking it back.
Okay.
I might be him, but I think that. No
I'm
one
just
in there's an
making
out,
sure.
that's
As you prepare to stabilize the patient for transport, he begins to vomit. While maintaining manual cervical C-spine, it was a good thing you didn't put him on the backboard. Maintaining manual cervical C-spine stabilization, the child is log rolled using a coordinated movement. Sectioning is performed to clear the airway. After sectioning, the child's oxygen saturation falls to 90%. His respiratory rate decreases to 16 breaths a minute, and work of breathing increases. Your partner immediately begins bag mask ventilation. So,
Yeah, they sectioned.
so question is this something, of course, we're going to go to the level 1. Are we going to still be on scene with this patient?
No.
No.
Okay, so what are we going to do if we don't have our partner? Because our partner's going to be up front.
You're gonna have Lucas.
You going to take a Lucas with
We'll
you?
take
Yeah.
Lucas with us.
Okay. All right.
If this
Somebody will
goes
go
bad,
with us, yeah.
Well, yeah.
All right. So what do we think here? What's
We
happening?
need to intubate. Need to knock his ass down and intubate.
Okay.
Well,
Can
we're
we
not capable of that.
do RSI
Sure we can.
on a child?
Sure we can.
What's the contraindications?
I only got a head injury.
All right. So what's our age range on RSI?
I think it's 14.
Shit, we got 3 people here that can do it.
If we had the drugs.
Yeah, I think we have drugs.
So Allison, Randy, oh, I never got certified.
Oh, okay.
I can, but I can't.
Yeah, yeah.
No?
Yeah, I was certified at one time, I thought.
Mm-mm. No. Andy won't certify him.
Just Randy and Allison.
Well, I mean,
You can.
I can, but I can't.
But could we call backup Spring River? Could we
Absolutely.
call
Are they RSI
Oregon
certified?
County?
Spring River's not
Spring-
RSI.
Oregon County is.
Oregon
Right.
County is what's.
Well, I talked to Lewis at church and they're introducing the protocols.
Oh.
So if they're not, they will be soon. Gotcha. No. But is Vitalink?
No.
Vitalink is not.
There's good things.
Well, I tell you, RSI, they're even thinking about
Same
taking it
thing
out.
about
Are they?
Spring
Yeah.
River.
Spring River. I was like, oh my God, can you imagine Henderson being able to RSI people? Shit, she'll knock everybody down.
But they're really thinking about taking RSI out. But then there's nothing good that comes out of it once you're RSI. It's like the vent. Once you're on the vent, and they wean you off. It's
The innovate, I was right.
Recognizing the child is at risk for aspiration, you measure the child using a length-based resuscitation tape and gather the appropriate intubation equipment. The child is successfully intubated with a 4.0 uncuffed ET tube using inline cervical spine stabilization for the potential cervical spine injury, which I think goes along with neurogenic.
Mhm.
You confirm ET tube placement by direct visualization of the chords, bilateral breath sounds, and a positive CAPNO waveform and ETCO reading. David said, no, that's a big word.
use small words, David.
Obtunded child can be intubated without the use of drugs.
David, we don't care what religion he is.
I agree with that. Here we go.
Obtunded, they pray to broccoli.
David, everybody wants to know what obtunded means.
Remember, David, not all of us failed or passed hooked on phonics.
Decreased LOC.
Thank you.
When do I work with him next? I'm gonna have to talk. Hillbilly, just say.
Okay.
Them slow kids.
All right. So cuffed versus uncuffed. Thoughts?
I hope I on the football field, coach.
Yes.
No, I'm leaving. I gotta go home and go to bed.
We don't want to watch it. Comma.
Where are you going?
All right, good luck.
I stay here that long? Are you good for that long, or you gotta go?
He's great.
Whatever you want me to do, babe.
Stay here till I get
Okay, well, lead it on, Cap.
He's good till Thursday.
done.
And we're talking about innovation. You're conscious, but I can get a tube down your throat.
I got a Jagger clip.
Well, you won't when I'm done.
Though, I was gonna be coffee. 6:00 this morning.
All right, cuffed versus uncuffed. Pros and cons.
Aren't they getting rid of?
Well, cuffed, you can't get away. Uncuffed, I can get away.
Oh, you can get away. It's just more difficult.
Buddy, I made it all the way to the US border cuffed.
Oh, I mean, cuffed.
And then federales was right up my butt.
I would do. I'd prefer uncuffed.
Why uncuffed?
Smoother.
Oh, so.
Do we have one in here?
Right behind you.
They have a smaller airway too, though. I'm not gonna lie. I really don't. I don't know the difference. I mean, I know the difference, but with
Right.
with a child.
This is for you all in Zoom land too. Cuffed versus uncuffed.
But aren't they
For
getting
some reason, they always recommend pediatric being uncuffed.
aren't they getting rid of
They're getting rid of
I
it.
thought so. I thought everything was
Uncuffed?
gonna be cuffed.
Well,
Yeah.
they've said that for several years now, and it
Well, I
hasn't
just
quite
heard
happened.
now about it being taken away.
In the box, in
What box?
that box right there behind you, there's all kinds of shoes that are.
This?
No, the clear box.
The one you just grabbed.
Yeah, the one you're holding on to.
It's a
There's two at
screwdriver.
the yard.
Probably can't have nice things.
Oh, you don't even want to know what I tore up last shift.
Lord, what did you tear up last year?
Everything. All the
That's
When
why-
did
things.
it start
She
coming
touched
like
it.
that?
That's a key.
I mean, but when did they start packing them like
I've
that?
always packed them.
No, they haven't.
No,
No.
I mean, ours at back, just this, you gotta have your own. Look, I'm not, no.
It may be the next one up, sweetie.
So John,
think we're all
somebody-
I slept in the spare. Or the couch.
I don't know when you slept in my bed and she slept in the other bed.
No, I just used it out of the room. I didn't
Okay, carry on, I'm done.
ran and then jumped, dove in there.
All right, so David said unless things have changed, they are still suggesting uncuffed. Terry said yes, uncuffed.
Okay.
Yeah.
I got one right.
Well, it literally said uncuffed.
Well, I was just asking what everybody's opinion was. Discussion.
That girl here does say it.
I haven't slept since fucking Sunday, so I don't know what it said. I just went with one.
You then secure the ET tube at the 12 centimeter mark at the teeth. Your partner continues to provide BVM ventilations at a rate indicated with waveform CAPNO and ETCO readings while you reassess the patient. You and your crew apply a C-collar, which I would have assumed would have already been on.
Or Lucas had a sick collar already.
Well, no, this whole time he's been holding C-spine.
Poor kid.
Okay, so it says secure the child to a pediatric spine board, which we already discussed, spine board versus pediatric board. And pad the voids with a blanket. You load him on the ambulance and cover him with a blanket and keep him warm.
You gotta worry about that in 12. It's like a damn pizza oven.
It is, 13 is too.
Oh my God.
Who keeps putting a damn heater in 13?
Which one's 13?
The one here.
The one here.
Well, we
no.
had to because Jeremy busted the,
Oh, yeah, Jeremy ran over the damn cord line,
so it has to be in
so
there.
you have to have the heater in there.
Even when it's 75 degrees outside?
Well, no.
Well, no, but at night.
It was like 60 last night.
I understand,
Well,
brother,
that's fine.
but yeah, you,
That's the
because the
first 60
onboard
degree
won't
night we've
work.
had.
Well, it will now.
Fix it? Or,
Yeah.
oh, cool.
Like now nobody can run over it. It's hanging
It's
down.
hanging down in the middle. So,
And yeah.
Good job.
But now I'm trying to get him to run the other plug, the 110, down the same deal where it can just be plugged and ejected and
Yes.
swing.
that'd be nice.
But when we get 03 back, it don't have that. So I'm gonna ask him if how the 03 is already just dropped single.
Yeah.
Mhm.
We'll have that, but then the bay over will be the double.
Yeah, right,
hanging
because
down.
that's the only truck that has.
right.
the-
But
yeah.
we've only got the one main short
Yeah.
line.
That'll be good. That's what I want to do in Mammoth, is run it to the carport, because where it's at now, it might keep tripping over.
What?
Yo, yeah.
But I will admit, I forgot. I did not know that you guys had the heater plugged into that one day. And I got in the truck and unplugged it and took off. And then I come back, I seen a yellow extension cord drug out. And I was like, what the hell is that for? And then I looked and I got a black cord hanging out the side door of where the heater was plugged in. We had an auto release.
Not on purpose.
Coming down here one day, it had 50 foot of orange extension cord behind the truck. Going,
Okay, that was off topic. I'm sorry. I'm stupid.
We'll talk about what I tore up and what Mike tore up this last shift. I recorded everything. I had a list. When Zirkle relieves me, I'm like, okay, I tore this up, I tore that up. He's like, well, one thing you didn't tear that we thought I tore up.
What did you tear up?
Well, we'll talk about it. Actually, let's go ahead and take a break
Okay.
because it's been like an hour.
You have
so
chat.
We have a chat. My opinion is use cuffed, just don't necessarily completely inflate the cut.
Sounds good.
Okay. Awesome. All right.
Now, is that if they're, whatever you said they were? or
Obtunded.
Obtunded? Or can we do it if they're rotund? Grandma and I are rotund.
Do what?
I'll have to drag all my stuff in,
You got quite a bit.
just different devices.
Well, good. Get some education. All right, so our 10-minute into our reassessment, our skin is still pale and cool. Pulse rate is 174, regular, weak distally, but strong centrally. So what was it before? 170?
170.
Okay, so are we really concerned about 174?
No.
Are we concerned about weak distally but strong centrally? Okay. Why or why not?
Well, because, I mean, we already know he's in shock, so
Mhm.
we know.
We're expecting
it's hypovolemic.
Okay. All right, narrow complex tachycardia on our cardiac monitor. Concerning or not concerning?
Not
Okay. Blood pressure 78/46. Concerning or not concerning?
not concerning.
All right, our respirations have dropped from 40 to 20 with a BVM. So we're ventilating for him, right?
Yes.
Okay, so that's not concerning. O2 set 97% on a BVM with 100% O2. Pupils are equal and reactive to light, which is a good sign. All right, 4-second cap refill.
Those are slow.
Slower than what it was?
It was 2 to 4 seconds, or 2
2
to
to
3
3.
seconds. Now it's on the 4.
Okay, so is this something to be concerned about?
Yes,
Are we expecting it?
yes.
Okay. Is this child in shock?
Definitely.
Definitely, but incompensated.
Okay. Currently, he's in compensated shock on the blood pressure, which is higher than the minimal acceptable blood pressure. The formula for calculating minimal blood pressure for children younger than 10 is 70, which is what Tim was talking about, plus 2 times the age in years. It is important to note the blood pressure has decreased 8 points since the first blood pressure cap refill is longer and the heart rate continues to increase. So the patient is rapidly moving toward decompensated shock. How should your management of the patient proceed?
Faster.
Lights and sirens, turn the lights and the sirens on.
Diesel therapy.
Okay,
Watch your fluids.
all right. So we got an IV, we administer fluids, and what did Tim say? How much fluid?
20
20
milliliters
bolus.
per kilogram.
Okay. Time is of the essence, meaning you should not spend a great deal of time trying to secure a peripheral IV. Are you going to drill this kid?
Yes.
Okay. If you have difficulty trying to find a vein, do an IO after securing vascular access, administer the fluid bolus. Based on the patient's vital signs and condition, you determine that he is in compensated shock. You insert a 20 gauge IV in both ACs and initiate a normal saline bolus. When you use the length-based resuscitation tape earlier, you estimated the child's weight to be approximately 12 kgs. So you plan to administer 240 milliliters. Is this going to be LR versus normal saline? All right. A chat. He is still trying to compensate, but maybe not so bad. Yeah, and that's probably me personally. When I would have seen those vital signs, I wouldn't have been as concerned with the indications. as what they're saying.
Mhm.
Because to me, it was just a matter of a few points as opposed to,
Mhm.
but in children, like we've talked about, they do go fast. So
Yeah, but you're already doing as much as you can right now, so
Yeah.
there's not really much more you can do.
yeah, and we had already planned on doing,
The bolus and
Yeah.
everything, yeah.
yeah.
That'll help get the blood pressure up.
All right, so okay. All right. You contact the receiving level 1 pediatric trauma center. The physician agrees with your assessment and treatment and advises no further orders at this time. So 18 minutes in, we're transporting. Skin is still pale and cool. Pulse rate 165 breaths or beats, a minute. Regular, weak distal pulses, but strong central pulses. Still a narrow complex tachycardia. Blood pressure 84/56. Respirations 20. Still with the BVM. O2 sats at 98% and 100% O2. Pupils are still equal and reactive to light. So if this patient started going into decompensated shock, what would we be looking for?
Your pulse rate going down. Blood pressure dropping. Respiration won't change.
Good. Anything else? Blood pressure dropping. Good. What's going to happen to his color? We're ventilating.
Should come back.
Okay.
It should start pinking up a little bit.
Even in decompensated?
Hmm.
He's still perfusing with.
But we're centrally, we're not distally. So is
Right.
he going to have some modeling, maybe?
Very possibly.
No, I mean, I'm asking. It's like a legitimate
I
question.
don't think his skin signs would change. Because he's already pale,
color will be bad, David says.
but the pale is already pale,
Yeah.
so.
So it'd be the next step. All right. What do you think is the cause for shock in this patient? Okay. What injury?
Abdomen
Okay.
injury, internal bleeding,
All right. Anything else?
fracture femur.
Good. Both injuries could lead to significant blood loss. Head injury can cause the blood pressure to increase as the pressure within the skull rises, masking increasing hypovolemia. So femur fracture, patient's only 2, so a traction splint would be, yeah. What would you do? Would you just let it free float?
Hmm.
Seriously.
Sam splints,
Cam splints?
Sam split, or the PD immobilizer.
Okay,
This what we was talking about,
okay,
because you can isolate every joint
all right.
with it.
So we know where the brake's at. How are we gonna, I know like you have the Velcro.
Mhm.
Are we gonna leave it open? That
Well-
side?
On the PD split, Velcro goes around the bottom of their belly. And the next one would be right above the knee. Next one will be right below the knee, the next one will be the ankle
Okay,
with it. So you actually, you could put them on that. And I don't know, there ought to be enough of us around that. Do that. You could actually tie a sandbag and put it off the end of your cot, to pull a little traction on it. After figure out a way to keep it where it wasn't bouncing and jerking this way, but
Where do you want to go sandbag at?
Make one.
one
With rock.
Give pillowcase.
pillowcase, fill it full of IV bags. You might be able to hang just an IV bag off of it and pull enough with it.
So how would you secure it to the body?
Furlex. Wrap it around the ankle.
Or let's go bend like a figure eight around the ankle.
Pull.
Okay. All right, so what criteria were used to determine that this patient needed transport to a level 1 pediatric trauma center?
Multi-system trauma.
So what's our GCS?
5 to 8.
All right.
Criteria for level 1, I mean, the height of the fall.
Oh yeah, he's got that covered.
Mm-hmm. So this says level 1 pediatric traumas have better outcomes at pediatric trauma centers. According to the CDC guidelines for the field triage of injured patients, the patient would be at least a level 2 pediatric trauma because he fell over 10 feet. And I didn't know this. This is pretty cool. Each story equals 10 feet.
Yes.
I did not know that. He meets level 1 criteria because his GCS is less than 14 and he was intubated on scene, which we discussed that we probably would have intubated him in route.
Absolutely. But we're feeling okay, so we just.
All right, so that is it for pediatric cardiac arrest, even though he didn't arrest. We saved him from being in cardiac arrest. Let me skim through. What is considered infancy? What is an infant? What ages?
Below 1 year.
What?
Below 1.
Below 1 year. So when does a child start to hold their head up?
Depends on the child, actually.
All right. Average.
I would say 6 to 8 months.
It says 2 to 6. That's good. When do they start to crawl and babble?
Already babbled from day 1.
I believe that.
He did. That kid would chew you out. He was like 4 weeks old.
So crawling and babbling is 6 to 12 months. The chat. Mechanism of injury versus GCS. That is a good point. What's a toddler age range?
1 to 4.
It says 1 to 2 for toddler. What it says. This includes the terrible twos. They're not capable of reasoning.
My child's still that way. He's 8.
I'm that way too.
So I know one was like 33, and she still don't reason all that well.
They have a poor sense of cause and effect, which is the reason why they're not capable of reasoning well. Language development is occurring rapidly. So the use of the pediatric assessment triangle to assess the child includes observation of general appearance, work of breathing, and circulation. We discussed that earlier. So strategies for examining, we know that we don't separate the child from the parent. We try to keep the child in the parent's lap. You get down on the level of the child, you talk to them in a manner that they can correlate with. Have the parent assist, use play and distraction when possible, offer choices, consider saving upsetting or painful steps for last, and be flexible on your head to toe exam. What is preschool age? We were at 2. 3 to 5, good. They can understand directions at this age, and they're generally able to tell you what hurts. Choose words carefully because preschoolers are literal. Using plain language and lots of reassurance. Fears are common. By age 4, the child develops 20/20 vision, runs, walks, throws, and catches, and kicks. They want to cooperate most times and are curious. And you want to respect their modesty. Let the child participate or hold equipment that is safe.
Careful of the
Avoid
shocking pad.
procedures in the dominant hand or arm. Why do you think that's so?
I think that's one they move
That's the
most.
one they move.
Okay.
Is that the book room at your house?
It's my whole life. We're all learning those big words.
We ain't damn rabbit.
Up and over.
She's in the front part, she both on us.
I don't think you should fit in a crop
I'm
pot.
at, oh, she can.
You don't need the big cast iron.
I got one. We'll fry her up.
All right, so what school age?
Well,
All right, good. 6 to 12, they are capable of abstract thought and understand cause and effect. School is important because it focuses on popularity and peer pressure. So children with chronic illnesses or disabilities can be self-conscious. They can understand death, and this can also increase anxiety. By age 8, anatomy and physiology are similar to those of adults, especially the ones that are like homegrown.
Mm-hmm. Tyson chicken.
Mm-hmm. Homegrown. Breasts develop between age 8 and 13. Menstrual periods begin between 9 and 16. Testicles increase in size around the age of 10.
I said he made it.
Yeah. I thought this was gonna say.
You made it.
Homegrown. What's an
So,
advertising for Tyson chicken?
good topics to talk with children at this age is asking about school, pets, and so on. They just provide a distraction. Rewarding is good for this age range after completing a procedure, which can help. What age is adolescence?
12 or 13, 18,
All right,
or 17. 17 or 18.
18.
That would be.
So this age kind of reverts back. They can be difficult. They're struggling with issues of independence, body image, sexuality, and peer pressure. Once secondary sexual characteristics have developed, breasts or facial hair, axillary hair, treat the adolescent as an adult, especially with respect to CPR and foreign body airway obstruction procedures. During your assessment, address and reassure the patient. Alienating the patient may interfere with assessment and treatment, encourage questions and involvement, address all concerns and fears, provide accurate information, respect patient privacy, if possible.
513 dispatch.
Address the adolescent without the caregiver present. Patient may want friends present. Let the patient have as much control as appropriate.
Fulton County 513.
So some of this I disagree with.
Me too, especially that last part.
Friends. Yeah.
You're gonna have more drama than trouble.
Yeah. Well, the reason why I disagree with it,
513 dispatch.
most times when we come in contact with these children,
Go ahead, Joel.
It's not the ones that come from good homes. It's not the ones that,
Everything's
No.
10-4 at 10629 Highway 62 West.
from good neighborhoods. And I
10-4,
think back to our foster care kids, your foster care kids, when they experience any trauma, let's just face it, I mean, cops, EMS can really
No
be
problem,
triggers.
anytime.
And
Let-
so they regress back to a younger age. And I remember having a 12-year-old that had legs longer than me rocking in a rocking chair to console her, needing that maternal figure. So even if they have body hair, it may be that you have to treat them more as a child as opposed to the age that is appropriate for them. So physiologically, they may be 12, 13, 14, 15 years old, but psychologically, they may be 7 or 8. And that maybe have the way that you have to treat them. And a good way of identifying that, and it's not always 100%, is when you talk to them in the way that they talk to you. Which I had an 11-year-old that was, gosh, she was smart, but like physically, she was about 14, and education wise, intelligence wise, she was probably about 13, 14, 15 years old, but her emotional status, she was about 7. So that's something just to pay attention to. They are.
My son the other day, oh, it was a couple months ago. He was doing something. I was like, "Oh my God, you have armpit hair." He goes, "You should see my ball sack." Did it get any better? Oh God.
Oh my goodness. Well, I like the little ones. Our age range was 6 to like 12 or 13. That was our favorite. Yeah. Yep.
14.
All right, so we all know that the head is significantly larger than the rest of their bodies. Infant's head is 2/3. An infant's head is 2/3 its adult size. Large surface area means more mass relative to the rest of the body, an important factor in the incidence of head injuries, which means that they tend to lead their fall with their head.
That looks like a tie. Sorry.
Seriously injured, younger than 2, place a thin layer of padding under the shoulders and upper torso to obtain a neutral position when you're trying to position the airway. Seriously ill, younger than 2, place a folded sheet under the occiput to maintain the sniffing position. Keep covered for warmth. So during infancy, we know the anterior and posterior fontanelles are open. We know not to touch them because they haven't been fused together. Anterior fontanelles closed by age of 2, posterior by age of 2 years. Posterior close at 4 months. So bulging suggests increased intracranial pressure. Would we have seen that in our 2-year-old?
Could have.
So this would have been the anterior fontanelles, right?
Yes.
Posterior by 4 months, anterior by 2. Sunken fontanelles suggest dehydration. So where do we want to check for pulses in kids?
Brachial.
Brachial, good. Carotid pulse is more difficult to feel or see JVD.
Most of them got chubby little necks.
Mm-hmm.
Get over that. Finders.
Nasal obstructions with mucus can result in significant respiratory distress. Epiglottis, theirs is long and floppy, U-shaped, narrow, and extends at a
just talking
45-degree
about the
angle into the airway. It's difficult to visualize the vocal cords during intubation.
I think he can be intubated.
Thank
You
you, sir.
think he can be intubated?
ET2, I take about a 7,
Was this
7
one?
and a half.
I don't know about.
I don't know about.
I don't know if I could eat.
Eat what?
ET2. I'll take a 7. I think it'll probably work. I may not gag on it too hard.
It'll be quick.
So young children experience muscle fatigue quicker. This can lead to respiratory failure if the child has to breathe hard for long periods of time. Infants and children will develop hypoxia rapidly with apnea and ineffective bag mask ventilation. Only use enough pressure to achieve visible chest rise. Use a larger bag if needed. That's the first time I've ever seen that. Yeah, because what we were talking about in
Using bags for
in
adults.
PHTLS, yeah. Maintain a pediatric O2 level of greater than 94. Take precautions with children who have uncorrected cardiac disease or a certain congenital defect. Circulation in the fetus is very different than in a newborn. Large right-sided forces on the EKG are normal in young infants. During the first year of life, the ECG axis and voltage shift to reflect the left ventricular dominance. Cardiac output is rate dependent in infants and young children. Relatively poor ability to increase stroke volume is reflected in their normal pulse rates and in the rate response to physiologic stress and hypovolemia. Mediastinum is more mobile than adults because let's just admit they're made of like rubber and glue.
Yes.
As opposed to.
They can bend themselves in the positions and I'm going, oh.
My daughter's Finley's that way. She is so flexible. It's like
Wouldn't cheer, I imagine so.
it's ridiculous on the things she. I'm just like the way she sits sometimes. It's just like child.
Oh.
So neurotissue and vasculature are fragile, easily damaged, and prone to bleeding from injury. Brain and spinal cord are not as well protected. Subarachnoid space is relatively smaller. That means there's less cushioning effect for the brain. The head momentum may cause bruising and damage, also known as shaken baby syndrome. So the pediatric brain, ironically, requires nearly twice the cerebral blood flow as an adult's brain, makes even minor injuries more significant, and increases risk of hypoxia. The brain continues to develop rapidly after birth. The spinal column in young children, the cervical spine of fulcrum is higher because the head is heavier, close to C1 and C2. The fulcrum descends to the adult level as the child develops around C5 through C7. An infant who sustains blunt head trauma involving acceleration, deceleration forces is at risk for a fatal high cervical spine injury. That's why I was really pushing neurogenic earlier. And even though Tim said that it was cardiogenic, and I do agree with that, or hypovolemia at the time, neurogenic would have been my first.
Booming.
Yeah. Yeah. So vertebral fractures and spinal cord injuries, which is just, and contraindicates what we just said, are in young children are uncommon. Spinal ligaments and joint capsules are more lax. Increased mobility and cord injury in the absence of unidentifiable vertebral bony fractures or dislocation. Vertebral bodies are aligned anteriorly and can slide forward. Potential for cord damage with significant forward flexion. The thoracic and lumbar spinal injuries are relatively uncommon, seen in children in association with specific mechanism of injuries, which is seatbelt associated lumbar spine injuries, compression fractures due to axial loading in a fall, which is pretty much what we had earlier, and a significant mechanism of injury, assume C-spine injury and transport with spinal motion restriction. Children have proportionally larger solid organs, less subcutaneous fat, and less protective abdominal musculature. Sorry. Abdominal distension in a healthy infant is due to weak abdominal muscles or larger solid organs. Liver and spleen extend below the rib cage in young children and are less protected by the rib cage, rich blood supply, so injuries can result in significant blood loss. Kidneys are more vulnerable to injury. They're more mobile, less well supported. Lower ribs do not shield them from injury, less protection due to underdeveloped abdominal wall and lack of fat surrounding the organs. The duodenum and the pancreas are likely to be damaged. In the handlebar injuries, organs become more proportional in size and better protected as the child grows. Pelvic fractures are uncommon. They're generally only seen in high energy MOIs. So the muscular system, I think we're all pretty well versed in that. So slipped capital femoral epiphysis, also known as SCFE, is a problem in the hip that affects the epiphysis of the femur. Occurs in children and adolescents, prominently found in overweight children. Considered a pediatric disease, gradual onset condition unless signs of trauma. This includes difficulty walking and a noticeable limp, inability to bear weight on a limb, and painful and limited normal flexion and rotation. How many kids do we like that are overweight do we actually see that in? I would say quite a bit. I mean, even if it's not pronounced.
Yeah, there's several.
Yeah.
When I took the Cersei, 13 years old and 400 pounds.
Oh my gosh.
Female.
Really? How tall?
A little over 5. Very was hard.
Really? So would you treat that patient as a pediatric or an adult? That's
How
wrong.
old?
13.
13. Well,
40 years younger than me, and I played me back.
well, I mean, it even says around 13 stuff you start treating them like an
Like an
adult
adult.
anyways. So really, I mean, by their weight, you'd still give them adult dosaging, obviously. So,
Yeah. So where's the Brazil tape in? Like what weight?
kilogram or both. Wait, what? What do you
What
mean?
weight does it stop at?
Yeah. Like when would you revert? Then I know you do it by height.
Oh, and if anybody wants it, for 99 cents, you can download the Broslow tape to your phone.
Oh.
Sometimes we don't have one readily accessible.
Mm-hmm. So let's see here.
36 kilos or 79 pounds.
Okay, so anything over 79 pounds, you're gonna have to treat.
Which you're at 12, 13 years old, they're over that.
Yeah,
So,
and treat them as an adult.
Yep.
Mhm. That's what that last foster kid that we had was at 200. Mhm.
Good Lord, look at Bryson Williams. He just turned 13.
Yeah.
Bryson's 150, 160.
He's a chunk. Sweet kid, but yeah, he is a
my God,
chunk.
that kid's good.
So injuries in the thoracic organs may be more severe, which we talked a little bit about that. Pulmonary contusions, cardiac tamponade, and diaphragmatic rupture. Lungs are prone to pneumothorax from excessive pressures during bag mask ventilation. So we want to, I agree to disagree with the use a larger bag. The only difference I can see in that is if you have a child and you grab an infant BVM and you're not getting it adequate chest rise, and so you want to go to the child BVM. Note that signs of a pneumothorax or hemothorax in children are often subtle. You may not see the signs of JVD. It may be difficult to determine trach deviation because of the neck structure. So be highly suspicious of non-accidental trauma. This would be accidental trauma caused by EMS, right? So we know the skin is thinner and more elastic. Higher body surface area ratio. We know how to assess these patients. We know how to do a physical exam. H&P. I think we're gonna call that good. Yeah. Well, no, there's 93 pages of this, but we're not gonna do that. You're welcome. You're welcome. We're gonna call that good for the pediatric cardiac arrest section. We're gonna go ahead and take another break and get set up for our next, which is stroke. But I think this is our last stroke category. So yeah, got a video I'm gonna watch. See you back at 10.